record. So acute renal failure is sudden loss of kidney function. Sudden loss of kidney function to excrete toxins and regulate fluids and electrolytes. Sudden loss of kidney function. So you have to tell the patient. The doctor said acute renal failure means your kidney have suddenly lost its function of removing waste and toxins out of your body. That's the best response to give to the patient. So, and what are the possible causes? So if there's a question talking about possible causes, what could have caused the patient to have that? And the possible causes will be infection, obstruction, and if the patient has a shock. So if a patient has a shock, that means blood volume that is supplying the kidneys to do the filtration has been reduced. And because the glomerulus is not getting enough fluid to filter, the patient, it can shut from its function. It's not getting enough, it's not getting full. If we remember the renal system that we did, I had mentioned what the glomerulus does in filtering urine containing the nephrons. So during the oliguric phase, and I also mentioned that acute renal failure has 3 phases. So we have the oliguric, diuretic, and recovery. Then during the oliguric phase, what will you see? These are specifics for the exam. These are specific for exams and what they will ask you for. So in the oliguric phase, it will last for only 1 to 2 weeks. Oliguric phase lasts for 1 to 2 weeks. So there's low urine output. So the patient's urine output will be less than 400. The urine output that the patient will put up will be less than 400. There will be hyperkalemia. Potassium will go up. High blood pressure will go up. BUN and creatinine will go up. And there will be fluid overload. This is what you see in the oliguric phase. So you are concerned mostly in that side. The diuretic phase, the patient is putting up a lot of urine, and that is more than 400 cc. So the patient is even putting up more than 2,000 cc a day. The normal urine output a day is 1,500 to 2,000. 1,500 to 2,000 cc or ml a day. So if the patient is in the diuretic phase, that means the urine is just coming. The patient is actually losing a lot of water than consumed. So what electrolytes do you think will be elevated? I mentioned all these things. I mentioned hyperkalemia, potassium will be high, there will be high blood pressure, BUN and creatinine will also be elevated. We also have 2 electrolytes that will be elevated, and that is sodium and potassium. Sodium and potassium. Sodium and potassium. But remember, in the diuretic phase, because the patient is actually losing a lot of things, urine output will be that's in the diuretic phase. Yes. So urine output will be more because the patient is losing more fluid, more than the 400 a day. So urine output is more. That means the patient will be gradually moving to the recovery phase at that time. So in that case, the diuretic phase, there will be hypokalemia and hypotension because the patient is losing a lot of fluid. So in the recovery phase, the kidneys are actually recovering through a slow process, and the urine output will increase and BUN gets back to normal. Recovery phase means it's stabilizing, it's getting back to normal. So this is all I'm going to say. And the next intervention that you are worried for, or the next intervention you will be mindful when a patient has acute renal failure, is for you to be monitoring the patient's weight every day. You have to put the patient on strict intake, input and output. You have to monitor them, INO treatments, and the cause of the renal failure and diuretics. So especially in the oliguric phase. So you have to identify the cause of the renal failure. Then you try treating the cause. If it's shock that is causing it, that means the patient is hypovolemic. Patient will need more fluid volume to be increased. The patient may need blood transfusion, more IV fluid to be given to help the blood volume return back to normal. So what is the best diet? What is the diet for a patient with acute renal failure? So the diet will be high carbo, low protein diet, high carbohydrate, low protein diet. Let's talk of another disease condition. This is how I want the discussion to go today. Clementina, I know you joined us late. I said today I'm not giving notes. Just get your pen and your pencil. I'm hitting them on what you may be questioned on and what you should do. So for a renal failure patient, the patient is in the oliguric phase and they're asking to know how much urine. I keep urinating every few minutes, every few seconds. And at least, what do I do? You need to understand that at the diuretic phase, there's a lot of urine that should be produced. So you have to explain to the patient, this is the stage you are in, and a lot of urine will be produced. So that is what we actually expect for this stage. So let's talk about a disease condition called Adams stroke. Adams stroke syndrome. Adams stroke syndrome is a problem that is part of heart problem. It's a heart problem. And okay. So when it comes to Adams stroke, what will the client experience? Adams stroke syndrome. The client will have a sudden stack of syncope and fainting. The client will suddenly become will suddenly faint and have syncope. Seizures may also be present. The client may also get seizures. These are the signs that come with Adams stroke. And what the nurse will see on the EKG. So if you do an EKG, you see asystole or you see ventricular arrhythmias. I wanted to discuss the EKG with you guys today, but I was like, no, let me not discuss EKG yet. I'll discuss EKG with you. It's either to discuss it or to do a video, but I want one that will be more interactive because I want to explain it so that when you see a rhythm, just on the facial look alone, you'll be able to identify it. That's enough for the LPN. So, so is there any tissue perfusion during this attack of Adams arrhythmia? Is there any tissue? There will not be any tissue perfusion. There's no tissue perfusion. The body tissues does not have a problem with oxygen exchange, or the heart muscle does not have a problem with gas exchange. If you remember the cardiovascular system with it. So the treatment, the client will need an internal pacemaker. The treatment for Adams stroke syndrome, the patient will need internal pacemaker, which is done through surgery. You know, we have the temporal pacemaker that is not through surgery. They just place it there to regulate it, just like the way they would do for nitroglycerin patch. But the internal pacemaker is through surgery. It's a surgical procedure. So remember, as a nurse, you have your preoperative care to do. So since it's a sudden attack, it will call for an emergency surgical placement of a pacemaker. And the oral medication that will be given after the surgical procedure is digoxin. Digoxin is an anti-arrhythmia medication. So you give the patient digoxin for Adams stroke syndrome. Now let's move on to Addison's disease. I'm not going specific today. I'm moving to Addison's disease. So Addison's disease is low production of hormones by the adrenal gland. Low production of adrenal gland. We have glucocorticoids and mineralocorticoids. So when they are not being produced in sufficient enough for the body to use. So the major symptoms for Addison's disease is lethargy. The patient becomes lethargic. The patient becomes weak and lose weight. Lethargy, weakness, and weight loss. These are the symptoms of Addison's disease. You want to take note. So if you have a patient diagnosed of having Addison's disease, the patient come to tell you, or the patient come to tell you the patient has not been diagnosed yet, a patient walk in and say, I think the doctor once mentioned that I was having some hormone problem. I don't know what it is, but lately I have been feeling very weak and I keep losing weight. I don't understand. You want to start thinking Addison's disease. The patient's skin color will change. It will be bronze, it will be hyperpigmented. The patient will have hyperpigmented skin color if the patient have Addison's disease. So there will be low, the serum blood glucose level, will be low. So the sodium levels too will be high. No, sodium level and glucose level will be low in the patient's blood. And then potassium will be high. So sodium is low, blood glucose is low, and potassium will be high for this patient. So the treatment for Addison disease is to put the patient on a long-term glucocorticoid therapy, treatment. Remember, this is about the glucocorticoid and mineralocorticoid not being able to secrete enough. So you put them on a long-term use or lifetime. They just need to have that forever, because if that is not always produced enough, the patient will have all the symptoms going on. So to maintain the patient, you have to put them on a lifelong treatment. Now let's talk about allergies. What are allergies? So we have latex allergies. I'm going to talk about latex allergies. So clients who are allergic to latex may also be allergic to some food. So if you have latex and I'm not able to, you have latex gloves and I'm allergic to that latex, I will also be allergic to kiwi, banana, and chestnuts. So for patients who eat banana and they're allergic to banana, the next thing is to think that the patient will also be allergic to latex. So you don't want to expose patients that tell you, oh, my allergies are kiwi. I'm allergic to kiwi. I don't eat kiwi. So if your gloves that you, the nurse, is about to use to do the examination is latex gloves, you need to know you don't have to use that gloves. It's possibility that they can cross match and the patient too will get an allergy from the gloves you are going to use if it's latex. So latex has patients who are allergic to latex are also allergic to banana, kiwi, and chestnuts. So the patient can only tell you one thing. Nclex will ask you about one allergy, and they want to know which of this will you not do or will you not give to the client. Now, standard hospital precaution of things that contain latex. So what standard hospital equipment do you think will contain latex? These are questions that Nclex will frame it as a question and throw it to you. That's why I'm trying to mention them. So if you sit on the exam and you ever come across something like that, you will know how to tackle it. So blood pressure cuffs can contain latex allergy. I've ever come across a question like that. So it's a standard question. We have tourniquets. Tourniquets can contain latex. We have indwelling catheters, the foley that you insert. It can be made up of allergies, latex material. So indwelling catheter, tourniquets, stethoscopes, gloves, and BP cuffs are all things that can contain allergies. Okay. So this one is a question. It looks like it's a simple one. Emilia, you have a question for me? Or you want to contribute? I see your hand up.
Not yet.
Okay. So if a patient is allergic to IV contrast dye, this is a simple question. This one I'm asking it as a question. If a patient is allergic to IV contrast dye, what other thing, just like I spoke about the cross allergy with the latex and the latex and kiwi and banana and chestnut. So if a patient is allergic to contrast dye, the patient has to go for CT scan with contrast, abdominal CT with contrast. What other thing will you question the client? Having in mind what can be another allergy for the client because the client is allergic to iodine. I'm sorry, to the contrast.
Is it fish?
Iodine. You just said it, but it's iodine.
Oh, listen. Yes, both of you are correct. I didn't have to mention that. My mouth went too fast. Fish. We have fish and iodine. Yes. So if a patient is supposed to go for IV contrast, you want to ask the patient, are you allergic to fish? Are you allergic to fish? Are you allergic to iodine as well? Because most fish have iodine, like shrimp like this. So they may not just
shellfish, right?
Yeah.
Shellfish to be specific, or just any
shellfish.
Yeah, and we have shrimp too. Shrimp has a lot of iodine in it. So we have things that they will not mention iodine or they will not mention fish to you. They will tell you some kind of seafood. They can mention seafood. So you want to pick an answer that will have seafood in it. Or they will mention shrimp. They will mention shellfish, like you say. They will not specifically mention that is contrast dye the patient is going to get. So they'll tell you the patient is scheduled for a procedure and the nurse is preparing the patient. And the nurse realized that the patient states that she or he is allergic to shrimp. Which of the following orders will you question? You understand? So you question if the patient is getting any form of diagnostic testing with a contrast or with a dye. You will question that particular one. Okay, so if the patient is going for intravenous pylography or intravenous pylogram procedure, it's going to be contrast injected. So you want to question that as well. So take notice of that. Let's talk about anemia. Anemia. So we have 4 types of anemia. We have the aplastic anemia. We have the vitamin B12 pernicious anemia. B12 is also pernicious anemia. I discussed that in one of the, I think, management of care videos. I have it, I will give it out. I haven't given that out yet, but I discussed that, all the vitamins and the minerals. I have that taken care of. So you know which food material contain this. What does pumpkin contain? I'm mentioning pumpkin because my daughter brought a pumpkin to the house and every day they are just playing with the pumpkin like a football. Everywhere the pumpkin goes in this house. So I was teaching and they brought the pumpkin to me today to just look at the pumpkin. So I still have it on my desk. So you want to know what is in pumpkin. You want to know what spinach contains. So I have that recorded. So I have aplastic anemia. Let's talk about aplastic anemia, signs and symptoms. What are the signs that you will see? There will be decreased erythrocytes, decreased red blood cell, bleeding of the mucosa membrane. The patient will start bleeding from the mucosa membrane, and then there will be thrombocytopenia, elevated, I think, white blood cells. There will be thrombocytopenia. Then the treatment for aplastic anemia is blood transfusion, bone marrow transplantation. The patient will get bone marrow transplantation. This is a problem that has to do with the bone marrow. So when there's a problem with pernicious aplastic anemia, it's more related to the bone marrow. So the patient get the bone marrow transplant. That means the cells in the bone marrow are not able to help produce red blood cells. They are diseased, so they cannot produce red blood cells. So the patient gets bone marrow transplantation and the patient feels better. So transfusion is the most immediate action to have the patient back to function. Let's talk about iron deficiency anemia. This one, you will see the patient have low hemoglobin. low. This one, most ladies who have menstrual problems, who bleed a lot, who get a lot of heavy menstruation, they are at risk for iron deficiency anemia. That's why they will put ladies on iron. So take notice. So a lady tells you their menstrual cycle is like 1 week every month. They menstruate for 1 week every month. On the exam, you see a question like that. What kind of anemia? They want to know what is going on. You want to think iron deficiency anemia. The hemoglobin will be low. The patient will be pale. The patient will report of being fatigued. There will be tissue hypoxia. You see that they will look a little bluish, especially on the extremities, the peripheral side. So the peripherals will look a little bluish because there's not enough oxygen in the body that is supplying all the organs necessary. So a little hypoxic. And then there will be tachycardia. The patient heart rate will go up higher. That means the heart is doing a lot of work to push out blood that is not being produced enough. Iron is missing. So the treatment is iron supplements and daily changes, dietary changes. You teach them about their diets. They need to eat good to stay healthy. Patients, are you taking notes? Because I'm not giving a note on this. Okay, and then
Can you go down a little? You're going too fast.
you have to catch up. You are doing nursing, so you cannot catch up with the speed because I want you to take notice. I want you to just write like important details. That's why I didn't go with the whole content material. So I just have things that Nclex would like to hit on. So the next 1 week or so, I'll just be discussing disease conditions like that. When I finish, then I'll think maybe I'll go into the EKG or I'll go into pediatrics. I haven't described that, but I'll talk about pediatric conditions as well. So I am actually doing a general review, then going into detailed content. Okay, so take notice. If not, you might want to request the video and sit in a quiet place. Like I tell you, don't waste your time. If I want to go back and watch this video, I'm not going to watch it the time that I'll be distracted. I'm going to watch it at the time that if I miss something, I'm going to be able to catch it within that time, because I don't want to sit for 1 hour and then I get up and I'm like, what did I even learn? I'm not saying put everything in your head, but just have the understanding so that when somebody asks you, you'll be able to say at least 1 or 2 things from it. One day you sit on the exams, it's not everything you remember, but when you sit on the exams, you remember this sound, and then it starts speaking to you about a topic you will see on the exam. Sometimes it helps. That will give you a good memory than having you just chew everything. You cannot record everything. You cannot actually memorize everything. The Nclex has a lot to learn. So I was talking about, I just finished talking about iron deficiency anemia. Now let's talk about vitamin B deficiency anemia, pernicious anemia. I used to think this anemia, pernicious anemia, was baby disease. I don't know why, but growing up, all I thought was pernicious anemia was for kids. So the patient will look pale. The patient will have beefy red tongue, and there will be fatigue and paresthesia. And the treatment for this is vitamin B12, cyanocobalamin injections. So the patient will be coming every month getting an injection. So if a patient ever tells you, oh, every month I have to be coming because they said I'm anemic, I have to be getting an injection every month for some kind of anemia, you should know that it's pernicious anemia. The patient is getting cyanocobalamin. All the other types of vitamin deficiency disorders, they don't get an injection for that. They get some form of dietary changes and it works. But for pernicious anemia, they need an injection, and that is cyanocobalamin injection or vitamin B12 injection monthly. Sickle cell anemia. For sickle cell anemia, we know this is a trait, and this one is, it has to do with genetic traits of unknown cause. So in that case, you have hypoxic, you have pain, And remember sickle cell crisis. When a patient is in sickle cell crisis, you want to manage pain and provide oxygen or give oxygen. So oxygenation. So treatment will always be pain management and oxygenation, and they will always have pain, especially in cold weather. So patients like that, you want to educate them about exposure to cold weather. That can trigger a crisis. Now let's talk about amputation. You see how I'm jumping? We are going to amputation now. So amputation. So what are the complications if a patient has an amputation? You want to think of skin breakdown. There'll be skin breakdown. Phantom limb pain. You can never be wrong with that when it comes to amputation and the patient keep crying for pain. Joint contractures. There will be contractures and infection of the amputated site. So you want to take notice of that. So what is the best positioning for a patient post-operative after an above knee amputation? Now, above knee amputation is AKA. Below knee amputation, they'll put BKA. So take notice. So if here is my knee and they amputate above it, that's above knee amputation. If they come down and amputate it, they just want the leg side, the foot side come out, that's below knee amputation. So for a patient who has above knee amputation, the first 24 hours, you want to position them in the prone position. Prone position, you position them twice daily to prevent hip flexion. So above knee, position them in prone position the first 24 hours. You elevate, you tell them to elevate the amputated side for 24 hours. And then you put them in a prone position twice daily to prevent hip flexion. For below knee amputation, you want them to elevate the foot of the bed for the first 24 hours and then prone position twice daily to also prevent hip flexion. So it's basically the same thing. So the best position is to elevate for 24 hours and then prone position twice a day. And the reason for you doing that is to prevent flexion, hip flexion. Now, you want to encourage them because losing a limb, I have been walking all my life. Now I'm 53 years. I just had to get an amputation because I'm a diabetic and I have necrosis. They have to take my foot out. This is hard. Adjusting to loss of body parts is hard. So the nurse has to be supportive. You have to allow them the opportunity to express their feeling about their lost limb. So you have to be supportive. You have to be a good listener. Your communication skills will have to be good. You don't talk too much and you don't give them cheeky answers. You answer them appropriately. You answer them when you have to. So just be encouraging enough. And remember phantom limb pain. Phantom limb pain. This one, they still have a feeling that my foot hurts. There is more of a psychological kind of pain. So the moment the patient had the amputation, the patient will still be feeling pain at that side, thinking that it's my leg that is hurting. But actually the thing is cut off. There's no foot, but they have the pain that my leg is hurting. So the patient has above knee amputation. The patient tell you my leg hurts. Don't tell them it's not true. Please, it's phantom limb pain. It's one pain you want to take notice of. That it make the patient feel like there's pain seriously on the leg. So be supportive again and just be encouraging, therapeutic in your communication with the patient. Now let's talk about aneurysm. Aneurysm, A-N-E-U-R-Y-I-Y-S-M. Aneurysm.
But please, I've seen questions on this amputation. How will an amputee demonstrate that he acceptance of the surgery he just underwent.
How would they demonstrate acceptance?
Acceptance, yes. Is
Well,
it by looking at the wound or talking about it? Because I've had that question not once, not twice, and
it depends on the kind of talking they are saying. I can be looking at the wound and I'm like, okay, so looking at my situation right now, the next thing I want to do is get a wheelchair so that I'll be moving around. That means I accept. But the patient look at the limp and you see them nod their head and the patient is like, I just don't know how this could happen to me. I just don't know how I'm going to walk around. I was supposed to be at a party. I was supposed to be in a meeting. I was supposed to travel to China. I just don't know how this is going to, I don't know how I'm going to travel with my friends. And I don't know how my people will see me. I'm not coping well with that. I haven't accepted that. So it depends on the kind of communication. Every communication can either be good or can either show acceptance or show that the patient has coping problem. So it depends on how the question is framed. So you want to understand that positive communication by the person will show that the person have accepted it. So the person says, okay, so I'm not letting this stop me. I'm still gonna go ahead and I'm gonna get different ways to still get my job done. I'm a security officer. I am still gonna work with my employee to see how best they can have me adapt at the workplace. If they put the word adapt, you will understand that the patient have adjusted, so they will not put adapt. So the person will tell you, I will have to speak with my employee so that I still prefer to have my job, but if they can change my job status, let's say your job status demanded that you run and do a lot of lifting and you cannot stand, then the patient is understanding the problem. The patient understands that something different can be done. But when the patient tells you, I don't care what I've gone through, I'm still going to go back to my job, knowing very well that his or her job is a demanding job and would demand her to go and be lifting patients and go and be doing EMS job. That tells you there's no proper coping mechanism at that point. So you have to let the patient come again. Can you just repeat that? And the patient repeat it to you, and then you like, okay, so can we talk about this? You have to come up with a supportive statement for the patient. So it depends on how the question framed it. Just know that statements that are negative, that appear a sad feeling, tells you the patient is not coping well. Statement that the patient makes it look like the patient knows something has gone on, but the patient will still do this because it worked best in the interest of the amputee. That means the patient has coped and is ready to move on with life. Take the grieving process, for instance, and compare that with the amputation. If somebody loses a relative and every day crying, and at a point the patient just understands. So you ask the patient, so what really happened? And the patient said, oh, so she was just doing this and she complained about this and that, and then we lost her. That's all we can say. So it's fine, we'll continue on with life. That's good coping. But where I come to ask you what really happened to your auntie, and then you start crying, or when you start talking about it, you start crying, we are not coping well. So it all counts, it's part of grieving process, and coping mechanisms has to be in place. Can I move on?
Yes, thank you very much.
Do we all understand, please? Or anybody has a further question on that? So think of the negative statements, statement that will tell you as an individual that this person knows this is not possible, but the person wants to get there. There's no coping. But where the person knows something is wrong and the person is ready to continue taking their medications, that's fine. For instance, I had a patient that was diagnosed as HIV positive. The patient is a young girl in her early 30s. She come in, they do the blood work. She accepted, she consented to have it done. And when they did it, They told her to go home. They'll call her with the result. Apparently, she just accepted to have it done. She didn't have the mind of having it come positive. So when they call her with the result to let the patient know result is positive, she flew up. She started insulting the person that gave the phone call, and she hung up. She's like, I'm coming there right now. She walked in, and unfortunately, poor me, who didn't even know when that blood was drawn, was the one sitting there. She walked in and flipped up on me. She's like, you guys are lying over here. You guys are lying, and none of you speak the truth. You don't even know your job. You don't even know why you're doing blood tests for people. You cannot explain. How can I be positive? How can this go wrong? And blah, 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 blah. And she was not ready to listen to whatever I say. I'm like, you want to speak to the doctor further? Because I cannot discuss any result. I don't know. It's not in my job description to talk about your result for you. I just have to ask you some questions and then check you in. She flipped out on me. I had to call for help. So that's not coping. Hearing that news alone, she's already out of it, but it will take a couple of days. It takes the social worker to step in, interdisciplinary, multidisciplinary teamwork. So I had to call the social worker, call the doctor, call the nurse practitioner. They all come in, and everybody have a role. We call the case manager. They all have a role. They teach the patient, and it's not going to happen today. She went inside, she flipped on the doctor as well. So we just had to let her be for that day to display herself and go. But with time, she gradually coped up, and then she started coming to see the HIV clinic to take medications. She now understands that. But at that point, you cannot teach the patient. So when the Nclex give you questions like that, a patient is already upset and saying, my wife caused this, my wife this and that and that and that. You cannot teach the patient at that point. You have to let the patient explain themselves, express the pain out, anger. There's anger in them, let them express it out. So it's all part of the coping. So I was talking about aneurysm, right? So the next thing we wanted to talk about was aneurysm. Aneurysm is dilation. That is formed at a weak point on the wall of an artery. Dilation at the weakest point of an artery. So if this is my artery moving on and this side is weak, it starts bumping up. That's an aneurysm. I don't know who have seen it before, but for patients who do dialysis, and they keep using the same access site and keep poking on the same site, you see at a point, you see it bump out. That's aneurysm. So it's the weakest point of the artery, and it's dilated. So it's like some kind of oozing tissue fluid and blood accumulating to the site. So the symptoms of aneurysm, most aneurysm will be inside the body and there will be no symptoms. You will not have any pain to the side. You're just feeling okay. Unless there's an infection, then you'll be worried about. So usually, to know this is an aneurysm, you listen to it with a stethoscope and you hear a blowing bruit. You know, when you check in the dialysis access site or the venous placement site, the AV shunt, you listening to it, you are supposed to hear trill and bruit. If you are documenting for that, the sound you hear is trill and bruit for a dialysis access. In the case of aneurysm, you hear a blowing bruit sound with the stethoscope. So you put the stethoscope on that side, and that is what you hear. For some people, it could just be a wound that they had and the wound got healed, and on that side, it's not contracted, but you see that there'll be some bumping up on that side. So the risk factors for aneurysm is infection, smoking, hypertension, and atherosclerosis. So the treatment for aneurysm is usually surgery, but that depends on the size. It depends on the size. If it's not too big, there's no need for surgery. So strict blood pressure control with medication is also another treatment for that, because you have the blood pressure altered, oozing to one side of the body. So the signs and symptoms of a ruptured aneurysm. So if, for instance, because the blood has been pumping onto that side or accumulating to that side, it ruptures, it bursts, what signs will you see? You see that the patient will complain of severe pain to the side. The heart rate will be increased. There will be tachycardia, and then level of consciousness. There will be decreased level of consciousness and hypotension, low blood pressure. Remember, if it ruptured, it's a lot of blood that will go there. There was blood already going there, a lot of blood will come out. So you want to teach the patient, for the sake of the Nclex, if you are the nurse, or if Nclex give you a question, what you want to do is to teach the patient to avoid straining, to avoid lifting or exertion, and to take their medication on scheduled time. They should schedule their medication and they make sure they take it on this time. And then you report severe back or flank pain. Severe back or flank pain. That's your tips, the point you need to know, the teaching you need to know and tell the patient with aneurysm, especially if they also go for surgery. If they have a rupture and they got a surgery done, you want to teach them to avoid straining and lifting. Teach them to take their medication regularly. Apparently, every patient, I would teach them to take their medication as scheduled. And lower back pain and flank pain is a question mark. I want to jump onto anorexia nervosa. Anorexia nervosa. So anorexia nervosa, if we remember that, it's usually found in adolescents. It's usually adolescents who get it. They are the most risk age group for anorexia nervosa. And the main thing you will see in a patient who comes to you and has anorexia nervosa is starvation. They will starve themselves and they start getting thin and thin because they have the reason for that. So take notice about this. I don't actually remember the exact question, but I have come across a question that was talking about why. I am trying to frame it, but the question wanted to know what you look out for in a patient as their reason for starving themselves in anorexia nervosa. The problem was the description of the patient and everything was talking about anorexia nervosa. And their problem is because they're adolescent, they have distorted body image. They feel like I'm either too big, I'm too this, I want to be sexy, but these are adolescents, not teenagers. So take notice. And the personality type that go into this starvation business are perfectionists. Perfectionists, overachievers, and low self-esteem people. People that feel like I'm just not worth it. They will normally become that. And the GYN issues, the gynecological complication for anorexia is amenorrhea. There is the menstrual, they have a problem with their menstrual cycle. So they have amenorrhea. Remember, they have not even started menses. Some adolescents don't start early. So some adolescents have not even started getting their menses. So they will have amenorrhea. And the cardiac complication will be cardiac arrhythmias. Cardiac arrhythmias. So don't be surprised when you see an adolescent taking digoxin, because digoxin is an anti-arrhythmic medication. So if they tell you the adolescent is taking an anti-arrhythmic medication or is taking digoxin, which you should know is an anti-arrhythmic medication because they have a problem with their body image. Which of the following which of the following diagnosis do you think will be the problem? It will be anorexia nervosa because their cardiac problem will be arrhythmias. So treatment and recovery. For you to treat them as a nurse, nursing, you want to encourage them to eat small meal, frequent, and then they need counseling. And in a quiet environment, in a milieu therapy, they always call it. So you want to teach them to eat small foods at frequent intervals, and they should also go for counseling. Let's talk about appendicitis. Appendicitis will occur in 10 to 30 years old. These are people more highly at risk. 10 to 30 years old, they are mostly at risk for appendicitis. So the patient will complain of acute right lower abdominal pain. For those I did the GI system with, they can best bear me witness to this, that I had explained that. So the pain will be right lower abdominal quadrant. The patient will have right lower abdominal quadrant pain. That's where the patient will point the pain to at. So there are signs and symptoms that the patient with appendicitis will present will be loss of appetite. They will have nausea and they'll be vomiting. They will also have low grade temperature. So the patient said, I have lower right abdominal quadrant pain, and usually there will also be abdominal tenderness. So the patient has nausea, vomiting, and you check the patient has a low grade fever. The patient has a temperature of 100.1 or 199.9. You want to question this because of the location of the pain. So when you do abdominal palpation and the patient stops, you touch there and the patient says, this is where the pain is, or you touch there, the patient will withdraw. Sometimes some patients doesn't show you pain. So another way to check for pain is when you touch there and the patient withdraw. Just like when you are doing the Glasgow Coma scale, sometimes you use pain to know if the patient will withdraw, to move, to tell you there is response. So there will be tenderness that is localized, and that tenderness will be at the McBurney's point on the abdomen, McBurney's point on the abdomen. That's where the tenderness will be. Then the test that they will do to determine that this is appendicitis, the blood work or the lab test, that diagnostic test that they will do will be complete history, the patient explaining the problem to you, and then physical exam. Physically, when you exam, you feel the tenderness on the McBurney's point, and then you also see the patient withdraw to pain, or the patient will point the pain to you. White blood cell will be elevated. There will be high white blood cell, elevated WBCs for a patient with appendicitis. And the treatment for appendicitis is usually surgery, and especially if there is ruptured appendix. Last time I was talking about it, you have the abdominal content mixing up with the other cavities in the stomach. So you don't want the leakage of fluid in the body. Actually, one thing I have searched that I didn't find was the actual purpose of the appendix. I don't know what it does in the body. I have been reading and searching for information as to exactly why God created it, but I think I just ended up in my own mind that maybe it was created to cause a closure of the colon, so that at the end of the ascending column to have a point to close, descending column, so that to have a point to close. I think it's the ascending column. It's on the right side. So at the ascending column, you see the appendix as a little small thing ending it. So it serves like a zipper to just close the whole thing. So because of that, you can take it out and you are fine. You don't have any problem. It's not like if it's on the intestine, then you end up on a colostomy and all those things. It's not like that. So the appendix can actually come out, especially if it ruptures. So if it ruptures, then it's going to need an immediate surgery. It's an emergency surgery. You always give antibiotics and you position the patient in Fowler's position. And the moment the patient tells you, describe the pain to you, you quickly want to put them on NPO, nothing by mouth, until all diagnostic tests are done to rule out appendicitis. So NPO, no heat on the abdomen. You want to assess the abdomen for distension, and you want to give IV fluids. Remember, there was elevated temperature or low grade temperature for that patient. Let's talk about Asperger's syndrome. Asperger's syndrome, ASPERGER' syndrome. Don't mind my pronunciation. Sometimes I'm weird. Asperger's syndrome. So it's a form of autism, okay? Asperger's syndrome is a form of autism. That's it. So if Nclex they don't want to mention that a patient is autistic. They mentioned the mother said, or the child has been diagnosed as having Asperger's syndrome. You just want to take notice that Asperger's syndrome is autism. It's all about autism. So you're going to care for these patients in the way you care for an autistic child. So their main treatment is for you to focus on communication and social skills. That's it. You don't do much. So for autistic people, your approach to them, sometimes they feel threatened. So you want to be calm, you want to be nice, approach them nicely. Social skills. Their problem is how to associate with people. I just want to chip in this arterial blood gases. Arterial blood gases. And arterial blood gases, they are the most sample that we draw, and we draw them from the radial artery on the wrist. Here, the radial artery on the wrist. We do ABG there. ABG, radial artery on the wrist. You can do VBG here. That is fine. The venous blood gases, you can do it here. But remember, we also have an artery here. We have vein and artery here in the brachial portion. But mostly, if you want to do arterial blood gases, you do it here. It is very painful. You do it from here, from the artery. So you have to apply pressure on the arm. You have to apply pressure on the site after you have taken the sample. So I have finished drawing the blood. The site is bleeding. I have to apply pressure for at least 5 minutes. You have to hold it for 5 minutes. It's not like venous. Artery bleed fast and artery bleed a lot. So if you puncture the artery, it bleeds a lot. So the pressure that you apply is 5 minutes. They may not question an LPN for this, but they may want you to know how long you have to put the pressure for. Is 5 minutes. And it's always taken in the brachial artery on the wrist. No, radial artery on the wrist. So usually we do the ABG for Allen's test. Allen's test. Let's talk about almighty asthma. Asthma. So asthma is an obstructive airway that causes spasms and inflammation of the bronchioles. Obstructive airway that causes spasms and inflammation of the bronchioles. So the signs of asthma will be shortness of breath, tachycardia. We all know about expiratory wheezing, and possible a cough. A patient with asthma will always say that I've been having cough. I always cough. So the client will experience the cough mostly in the night. So cough is mostly in the night that they experience more cough. So you want to treat asthma by identifying the cause of the asthma. For instance, you identify what triggers it. You identify the trigger factors. Yes, that's what I wanted to say. The trigger factors is very necessary. So to treat asthma, you want to give anti-inflammatory medications. You want to give corticosteroid, bronchodilators, leukotriene modifiers, metered-dose inhaler, and bronchodilators. Bronchodilators. Now listen, if a patient has asthma, why do you think they will give the patient magnesium sulfate? Who knows why? And at what point do you think magnesium sulfate will be given? Who knows why? And who knows when? So if a patient has asthma, first of all, you want to give bronchodilators. That's your nebulizer treatment. You want to start with the bronchodilators. And if it doesn't work, you give steroid. Steroid doesn't work, then you give magnesium sulfate. Magnesium sulfate has an effect of relaxing muscles. That's why if a patient has seizure, you can give it for seizures. Remember, magnesium sulfate, most people or most students think magnesium sulfate is only used in eclampsia or pre-eclampsia. Used in pre-eclampsia for seizures, to prevent seizures. So even though magnesium sulfate is used in preeclampsia, just catch this. We use magnesium for seizure disorders as well. Magnesium sulfate, not magnesium. We use magnesium sulfate for seizure disorders as well. So a patient having serious respiratory problems and is asthma, you give bronchodilators. Magnesium sulfate is not a bronchodilator.
Used to antispasmodic, right?
Yes.
For spasm, yeah.
Yes, it's an antispasmic medication. And remember the definition for asthma is I said asthma is the obstructive airway disease that causes spasming and inflammation of the bronchioles. So if it's an antispasmodic medication, and then you give the bronchodilators will have to do with the nebulizer treatment that you give. Remember, inhalers and other stuff, the patients take those things usually at home, but in the hospital, you want to relieve it right now. So you have to give the bronchodilators. Yes, it's also a smooth muscle relaxer. Yes, that's what it is. So if it's antispasmodic, it's about spasms. So it's used for seizures. It will relax the patient's muscles and it will relax the patient bronchioles and have airflow to be easy. So some patients, after the nebulizer treatment, after the bronchodilator, it doesn't work. They give the steroid. Steroid is supposed to open up the airway. It still doesn't work. Then you go for the one that will relax smooth muscles, the one that will relax the bronchioles, so that it will relax it and open it, and the patient will be breathing well. So usually magnesium sulfate is the last treatment. Okay, it's the last treatment. You can use it if a patient has a seizure. So don't be surprised when you see that being used in seizures. Okay, so on this note, I will talk about autonomic dysreflexia. Autonomic dysreflexia, that's another condition. But let me look at my time. If you want to take a break, you can stop me. It's okay. You can say, oh, hey, we need to stop here. But let's look at. I remember the last time I had asked you guys how to teach a patient how to use a nebulizer, a metered dose inhaler. Like if a patient is going home, you are going to give them a nebulizer treatment. How will you teach them to use it in the house? I remember I had given you guys the instructions, but let me just go over it. So to teach a patient, Nclex, if Nclex wants you to do this one, they will want you to do it as a drag and drop. Drag and drop. So most of the quizzes I give you, some of them are drag and drop. But because I don't have the drag and drop system, they'll tell you to arrange them. So arranging them will means they'll have like 5 answer options. They want you to arrange them from correct to wrong, or from wrong to correct. That's what drag and drop will do for you. And on the Nclex, don't always think that it's always the right side. They can reverse it. They either want you to drag it starting from the wrong thing to the correct one, or starting from the correct step to the wrong step, and the final one you will do. So first of all, you want to remove the cap. So if this is my nebulizer treatment, I'm going to send you home, and I have to teach you how to use it at home. So I'm going to drag these answer options and drop them, but I'm actually supposed to be teaching a patient. That's what Nclex is doing. So the dragging and dropping is the teaching you are doing. So first of all, you tell the patient to remove the cap. So I remove the cap. Then you shake it well. Tell the patient to shake it, and then they break out away from the inhaler. So they want to breathe out. So don't put the inhaler yet, but you want to breathe out. So you let them breathe out, and then they bring the inhaler to their mouth, then they place it in their mouth, in between their teeth, and then they close the mouth around it. So you put it in your mouth after breathing out, and then you close it, you make a seal of it. Then you start to breathe in slowly. And whilst you are breathing in slowly, you press on the top of the inhaler. You press on the top, and then you keep breathing in slowly, and you hold it until you have taken a full breath. So 3 to 5 seconds, you hold it. So after you press it, you hold it for 3 to 5 seconds, and then you take a deep breath on it. Then finally, you want to remove the inhaler from your mouth and hold your breath for about 10 seconds. And then you breathe out after that. So if the patient cannot tolerate a bitter taste or is experiencing any side effects, they may need a pacer. They may need you to use a pacer for them. So you tell them to rinse their mouth after the dose to prevent any thrush or any uncomfortable feeling. So they rinse their mouth. So they also need to wait for at least 1 minute before each puff. So if I have to take one inhaler that is albuterol, then I'll have to wait 1 minute in between. But if there are 2 different of them, then you have to wait 5 minutes in between the medications. Wait 5 minutes in between each medication. So let's talk about autonomic dysreflexia. What is autonomic dysreflexia?
When you talk about inhalers and what is the space and what's the difference? Is that in the way of application or in the way of the equipment, the inhaler with a spacer and without a spacer?
I don't understand the question. Can you come again?
What is the difference between an inhaler and inhaler with a spacer?
Oh, so you are asking about the difference between an inhaler with a pacer and an inhaler without a pacer. Hello?
Yeah.
So the one with the pacer is the one that helps.
My internet is bad.
Okay. Yeah. So for patients that have like bitter taste in the mouth after using the inhaler, the pacer help them so that they don't have that bitter taste. That's just the most important difference. Besides that, it's not anything different. It's just the side effects of the inhaler that causes the bitter taste. So the one with the pacer will help them with that taste. The one that doesn't have the pacer, you don't mind. But the one that have the pacer is the one that help with the bitter taste in the mouth after they used it. So that's the difference, the side effect of the inhaler. So you want the pacer to help with that side effect.
Okay, thank you. I didn't know.
Okay.
Thanks.
So autonomic dysreflexia is this is a spinal cord injury problem. It's a kind of injury that a client gets that causes autonomic dysreflexia. And it occurs in clients who have spinal cord injury, usually T6 or above T6 on the spinal cord. So if you ever look at a picture of the spinal cord, I don't have a picture right now, I would have shown you, but take note, is autonomic dysreflexia, you will know it's nervous problem, spinal cord injury. So the stimuli, like what can it cause? What autonomic dysreflexia can cause is to cause stimuli such as full bladder and fecal impaction. So it can stimulate it can cause like a stimuli in the urinary bladder, and it can also cause fecal impaction, inability to poop. So the urinary bladder is affected and the fecal muscles too are impacted. So autonomic dysreflexia is life-threatening due to if the client becomes hypertensive. So that's a complication. So when you have a patient diagnosed with autonomic dysreflexia, and then you realize the patient blood pressure is going up higher, it's just like eclampsia. It's a life-threatening complication. You want to take note. So usually patients who have autonomic dysreflexia will have urinary obstruction. So the signs of autonomic dysreflexia will be increased blood pressure. That will be like 40 of it. So if the systolic is let's say 120, you want to add 40 to it to make it 160. So autonomic dysreflexia will cause an increase in your blood pressure at least plus 40 of the normal of your blood pressure, at least plus 40. So there will be headache, bradycardia, blurred vision, and sweating. Headache, bradycardia, blurred vision, and the patient will be sweating. Then the position when a patient has an episode of autonomic dysreflexia is high Fowler's. High Fowler's. But first of all, you want to check the patient's bladder for distension. If the patient has an episode right now, you want to check their urinary bladder for any urine, for any distension or any urine in there that is obstructed. So you also want to lose their clothing to help them feel good. Don't make them constricted. I know this generation will like tight clothing. So you want to make sure their clothing are loosed. So the treatment for you is to remove stimuli, things that, and the stimuli will be there encouraging the patient to urinate so that they will not have urinary bladder full or distended urinary bladder. You want to encourage them. So you encourage the client to void and to also use the bathroom, to also poop. Let me say that. Now let's talk about Bell's palsy. Bell's palsy. After this one, we'll take a short break. Bell's palsy usually affects cranial nerve, and that is cranial nerve 7. Cranial nerve 7. Cranial nerve 7 is usually the facial nerve. It's usually the facial nerve. So there's temporal facial paralysis that will affect your chewing ability and your eating and even your eye. So this is the complaint the patient will give you. The patient will tell you, oh, so I woke up this morning, I stood by the mirror, I saw that my mouth went one side, my mouth moved one side. It's not always stroke. If you're not careful, you will mistaken this symptom for stroke. You see a facial droop, and then you see that the eye, so you see that the patient will have a problem with the eye, vision can be a problem. They tell you, I'm not seeing well, but I feel the pain from here. The pain will be described around the jaw or behind the ear. That's where Bell's palsy symptom, those are the symptoms the patient will present to you, and you will be able to notice that this is Bell's palsy, it's not stroke. So the moment the patient said the pain is right behind this ear and on this side, and then I see this eye, I couldn't see well. And when I also realized, I saw my mouth turn to this side. So the problem is on this side, you see the mouth turn to the other side. It's just like when you see the stroke, it affects on this side, the effect go on the right side. So if the effect is on the left side, go on the right side. So you see the mouth turn to one side. So they will have problem eating. They will have paralysis, facial paralysis. Their face will be paralyzed. That's the drooping. And then eating and closing of the eye. So you can see the eye, like you see the patient sleeping and the eye is not closed well. So the patient is actually sleeping. You're hitting on them and they are deeply asleep, but the eye, one eye is open and one eye is good and sleeping. So that will be Bell's palsy. So the treatment for Bell's palsy is to have them wear a patch at night. When they go to bed, they should use artificial tears. They can use artificial tears and steroid to reduce the edema and swelling if there is any to the site. So usually that's the treatment for Bell's palsy. So on that note, any question? I will talk about, I think I spoke about BPH a lot, but maybe I'll talk of it when we come back. So we are going to take a break at this point and then we'll come back. Anybody has a question for me? Any question before we break out? So I'm just jumping from disease to disease, from problem to problem, and I'm going on specifics just for the sake of a review, so that if you need further of that, please, I want you to use this opportunity to be practicing on the questions, be using that to be learning and answering questions. You need to learn how to answer questions. If you know all this information and you see a question and you cannot critically think to sort it out, is a problem. So you need to know the information and you need to also be able to tackle questions to rule out what does not just does not just work for this particular condition. So for instance, I just finished talking about Bell's palsy, and I told you it's about the nerve. It's about cranial nerve 7, facial nerve. And I told you the main complaint, the patient will tell the pain is right here and it's on my jaw. And you see the eye, one eye cannot close the eyelid. So if the patient, they are giving you, Nclex is giving you a question on this. And then among the answer options, you see they're talking about the patient has shortness of breath. What has that got to do with Bell's palsy? What has that got to do with Bell's palsy? And then they tell you the patient has urinary incontinence. And the question was about Bell's palsy. You looked at the question, it was describing Bell's palsy. They can start with Bell's palsy and they end up jumping into BPH. They want you to answer the question under BPH, not Bell's palsy. So you need to be able to understand how you have to understand the question first. Understanding the question make a lot of difference. I have a lot of people or a lot of students read too deep into the question. They finish asking them the question and they go like, so I know there will also be this sign. And if this was not happening, no, the question Nclex give you is a complete question on its own. Don't think any information attached to it. Just make sure that you understand that in Bell's palsy, the problem is facial nerve and it can look like stroke. So even though stroke will come with facial droop, stroke will come with a complaint of headache, especially if it's bleeding. Stroke will come with a complaint of neck pain and all those things. But this one, you see the face move to one side, that's facial droop, and you don't see any fever. So you have to be able to understand the content and use it to answer the questions. But you can only answer the questions right if you make meaning from that question you read. If you cannot make a meaning from the question itself, then you know the content, but you are not able to understand the question, because sometimes the question will start with one topic and they jump to another topic that they want you to answer the question on. Don't come back and think that, oh, but they had talked about this one before. They talked about it, but look at what they ended up asking you to do. They ended up asking you to look for something different. So you have to try to make meaning out of the questions. That's why I want you to use the 75 questions to practice. It's not a 75 question that I want you to just use 15 minutes. I remember I had posted that because I had somebody make, somebody said was feeling bad of the score. That's not my point. I don't want you to just rush over it and then you get like 70 over 70 and you're happy if you cannot make meaning from the topics that are in the questions. I want you to understand it and understand how the question was framed in relation to the content material. I want people to get the understanding that Nclex is not about you being able to eliminate answers. The foundation for nursing and the foundation of you passing the Nclex is knowing your content material, because you are going to the floor to face it. You are not going to face a computer after Nclex. You are facing the reality of the human being, head to toe. So if you only know how to eliminate and you keep eliminating and keep eliminating, how long will you do that? So most people keep failing because they just think it's all about the bunch of questions I will buy and answer. That's fine, but you need to understand the baseline, the framework of that particular questions. They all have topics they belong to. They have disease conditions they belong to. And they want you to be able to tell the patient something. They want you to be able to figure out something. So if you don't understand the foundation of it, how do you figure out the product? You cannot figure out the product, because if they go and pluck apple and they pluck plums and then they mix them together and they bring red grapes and green grapes and mix it together, and you look at it and you cannot figure out this one is coming from a grape tree and this particular fruit is coming from an apple tree, this particular fruit is coming from the cranberry tree, you cannot sort those fruits out right. You see the trees there, but you will not know which one to go and put on who. So you will not know which one to attach to who. So the foundation for all this exam is the content. When you know the content, you now need to be able to understand the question. Take your time. Don't rush the questions. Don't rush the Nclex questions. Understand, when you start reading the question, please erase your mind from problems, erase your mind from family troubles when it's time for that. When you are answering the Nclex questions, make sure when you read one question, understand the question. So if you have a challenge reading the questions and understanding the questions, please let me know. I will get some few, I'll have you get some few questions, and then you tell me how you will analyze it, and then we talk about it. So you can let me know. So on this note, let's take a short break, and then we'll be back in 15 minutes, right? And 15 minutes will be 50. It'll be 8 o'clock. Okay, so we'll be back at 8 o'clock. We'll come back and do some few more conditions, and we get off the line, okay? I hope I'm not pulling you too much. BP. So it, like, the cause of it is actually unknown, but the prostate enlarges, and this is mostly in men. It's men who have prostate. So the people, or the group of people who usually get it, are men who are 50 years and above, men who are 50 years old and above. So it blocks the urethral opening. It causes blockage. The prostate will cause blockage of the urethral opening, and this will make the client have a couple of urinary symptoms. So the client will have to strain to urinate. They'll be straining to urinate. They will have decreased urine stream, decreased urinary stream. Let's say they start peeing, the urine is coming at a point, it's not coming with like that power. It's not coming with some kind of force in it. So they always feel like they have to go to the bathroom. That's the urgency. So they have the urine retention problem and dribbling. They keep having urinary dribbling when it's flowing out. So this is the problem. This is what you will see when you assess them. They'll be straining with urination, urinary frequency, and urgency. They have the urge to run to the bathroom, but they get to the bathroom and the urine is not coming with force. So those are the symptoms. So the best way to assess a patient for BPH, for the assessment process, they will always do a rectal exam. They do rectal exam to assess for that. And then the doctor will also have to feel like a pear shaped. When you try to do the rectal exam, you feel it as a pear shape. Tells in the rectum, tells you there's an enlarged prostate around there. So after the procedure, the client is at risk for bleeding. So you want to monitor the client for hemorrhage. You monitor their urine for hemorrhage because they're at risk for bleeding. Sorry. Okay, so they're at risk for bleeding. So you want to monitor for hemorrhage. So the doctor will also order for them to have like continuous bladder irrigation. So the people with BPH, they have to do continuous bladder irrigation. So they also get a Foley inserted. They can also get a 3-way Foley lumen inserted. And then the balloon inside is inflated, inflow of solution and outflow of urine. So the 3 lumen Foley that will be inserted, they have to, every Foley that you insert in a patient, you have to inflate a balloon. And then continuous bladder irrigation. So the goal for the irrigation will be to reduce blood clot. So this is usually done after a surgical procedure called transurethral resection of the prostate. That's when you need to do the irrigation to ensure that there's to reduce blood clots and to prevent blood clot as well. And if I go out.
No.
You're on mute. You're on mute.
I'm so sorry. I was doing that for this boy. So I'm explaining that the doctor will have to surgically go through the penis. They have to go through the penis, and when they go through the penis, they try to do the transurethral prostate resection. They use a scope to view inside, and they have to remove part of the prostate for further exam and further evaluation. So they want to know if it's carcinoma, if it's some form of cancer that is causing it. So after that procedure, the client is at risk for bleeding. So after that procedure, the patient is at risk for bleeding. So you want to monitor the patient for bleeding. So in order to be able to monitor the patient for bleeding, that's why they put the Foley there, the three-way lumen Foley, and then you have to irrigate. So before you be irrigating the Foley, you need an order from the provider. So the reason for the irrigation is to reduce blood clot, is to reduce or to prevent blood clot. So they will, if the patient has an indwelling catheter, remember the first catheter you insert is a special form of catheter that has 3 lumen. But if it's an indwelling catheter, there is no irrigation. You do not irrigate a patient after transurethral resection prostate, transurethral resection of the prostate. After that procedure, if the patient has an indwelling catheter, you do not irrigate unless it's the 3-way lumen Foley that is inserted. So you don't have what? Okay. So let's continue. What type of fluid that do we use to irrigate? So we use isotonic fluid to isotonic sterile saline. We use isotonic normal sterile saline to irrigate. So the color of the urine should be pink. It should be light pink. So when you start with the irrigation, you expect the urine that will be returned to be pink. So during continuous bladder irrigation, the client should be monitored for bladder distension, fluid overload, and hyponatremia and blood loss. You want to monitor the patient for that. So the best position for this irrigation process too is lying them flat and sitting up. That will put pressure on their bladder. So you make them lie flat. When you put them up, sitting up, there'll be pressure on their urinary bladder. So you want them to lie flat. So the discharge instructions that you give to this patient, mostly this procedure is like a couple of days, the patient will stay in the hospital. It's not a same-day procedure. So when the patient is going home, you want to encourage them to drink 2 to 3 liters of fluid daily. 2 to 3 liters of fluid. Remember, when I was talking about the renal system, I mentioned that anytime you are going to increase a patient fluid, it should be up to 2,000 liters. So 2 to 3 liters is 2,000 cc to 3,000 cc a day. They have to increase their fluid intake. So no lifting, no straining, we tell them. And if they notice red blood clots are present in their urine, like small blood clots in their urine, then they need to report right away. And you teach them how to do Kegel exercise to strengthen their pelvic floor muscles as well. So this is your education. That's what you tell a patient who have had transurethral resection done and is going home. Let's talk about breastfeeding. So any question on this, the prostate thing? Okay, let's talk about breastfeeding. So breastfeeding moms will always have abdominal cramps. So if a mother gives birth and is breastfeeding, immediately after birth, the mother starts breastfeeding, there will be cramping. And this cramping is due to the release of prolactin and oxytocin. Is because there's release of prolactin and oxytocin. That's why the mother will have bleeding. Yeah, the mother will have abdominal cramps, and that also help uterine contractions as well. So before breastfeeding, the mother should be seated upright and then hold the baby. So the benefit of breastfeeding is to give the baby passive immunity and quicker weight loss in the mother. Quicker weight loss. So the mother will lose weight fast when they breastfeed, and then it also increases bonding, and it is economically low cost. Remember, you have to buy formula. It will be expensive to buy formula. Let's talk about blood pressure, hypertension. So what is hypertension? So blood pressure that is above 120/80 is considered, if the systolic is above 120 and the diastolic is above 80 is hypertension. So I'm just going to jump straight to the advice you give to the patient who has blood pressure, the teaching. So you teach them to take their blood pressure medication, you teach them to follow up with their primary care, and you also teach them to avoid herbal medications like garlic. You teach them, no, the garlic will lower the blood pressure. So you teach them garlic is one of the, it's a herbal medication. I don't want to dig into the medication aspects of the hypertension because I have a lot of that to talk about. Have a lot of hypertension stuff with medications, the different types to talk about. So garlic is one of the home remedies to lower blood pressure. So you want to teach the client, if they take garlic, it will cause their blood pressure to be low. So if they are taking blood pressure medications already, there's no need mixing it. You can't mix a home medication with the doctor's prescribed medication. So you teach them that. Now let's talk about bulimia nervosa. I had spoken about the other one. Please, are we taking notice? I had spoken about, what was the other one I spoke about? I spoke about the one that is in the adolescents. And now I'm going to speak about the one that caused the starvation. Now I'm going to talk about bulimia nervosa. Okay. So bulimia nervosa is eating binges that is followed by purging. They have eating binges and followed by purging. They eat a lot and they end up vomiting everything. They initiate vomiting and they push it out. So so for this patient, the client will usually have their normal weight. They don't lose weight like the other guys. Anorexia nervosa, they don't lose weight like anorexia nervosa. That's their difference. Anorexia nervosa, the starvation, they don't eat at all because they are scared of their body image, usually adolescent. But in bulimia nervosa, the patient will eat a lot and induce vomiting and vomit. So these patients usually have their normal weight. And besides the purging, the other method they use to lose weight will be vomiting. They also use enemas, drugs, diuretics, and diet and pills. So remember, they have their normal body weight, but they still think something is not right. So the medical complication for patients with, remember, I told you anorexia nervosa, you are worried about cardiac arrhythmias. That's their cardiac complication. But for the bulimia nervosa, you are worried about tooth decay. They will have dental problems, electrolyte imbalances, they will have ulcers, and they also have cardiac arrhythmias. But remember, these people, their main problem will be the tooth decay. So safety is a concern for these people, and you want to watch them for suicidal ideations. Safety is a problem. Suicidal ideations is crucial in these people. So your treatment goal will be to encourage them to take safety, and you assess them for suicidal risk potential. You assess them for any potential of being suicidal. So you also want to encourage them to establish a dietary plan. You want to encourage them to establish a dietary plan. And for these patients, they have depression, they are depressed. So they take antidepressants as well. Now let's talk about bends. So what are the age group that mostly at risk for suffering a burn injury? Usually these are children and elderly. So the children age and the elderly people are mostly at risk for burn. So we have 4 types of burns. We have the chemical burn, electrical, and thermal burn. So if the neck, if a patient got burnt and the Nclex is asking you questions and they tell you the patient was burnt and the neck has a percentage burn and the patient neck was burnt or the patient face was burnt, what will you be concerned about? Who can tackle that? So if a patient neck was burnt and the patient's face too got burnt, what will be your concern as the nurse?
Breathing.
Airway, yes. So you'll be worried about airway. If it's the neck and the face, you can imagine your nose. So that's one thing you want to be mindful of. So for patients that has burns that has to do with the neck and the face, think airway. Now let's talk about classification of burns. First degree burns are superficial partial thickness. First degree burns are superficial partial thickness burns. So the skin will be pink, it will be red, there will be pain, and it just look like a sunburn. Okay? Pink skin, red, painful, and you can compare that to a sunburn. So when somebody have a sunburn, you see their skin. Anyway, my burn, I have a burn here, but my burn here was oven. I was cooking. So it's superficial too. It's stage 1, first degree. So let's look at second degree. Second degree, we have deep partial thickness. Deep partial thickness. Skin is red or white. The patient will have blisters and swelling. Blisters and swelling. So skin will be red or it will appear white. There will be blisters and swelling. Third degree burns is full thickness. Full thickness. The skin will be black or brown. There will be edema. All layers of the skin are burnt. So usually for third degree burns, they will need skin graft. Skin graft. So these are the types, the classification of burn. They will need skin graft. So the formula, we use a formula to replace fluid within the first 24 hours. And that formula is the Parkland.
Can you please go over the third degree again?
The third degree? Third
Yes.
degree is the skin will be black or brown. There will be edema. All the layers of the skin, starting from the epidermis, will be burnt. All the skin layers will be burnt. And the patient's treatment, patient will need skin grafting. So they use the Parkland formula to calculate the amount of fluid to give to the patient in the first 24 hours. They use okay, so they use the Parkland formula, and the Parkland formula is they take 4 ml of lactated ringes and you multiply it by the weight of the patient, which is in kilograms. So if the weight is not in kilograms, you have to convert it. So if they can give you a calculation on this. So if the patient weight comes as pounds, the patient weight comes as pounds, then you have to calculate, you have to change the pounds to kilograms, and then the percentage of body burnt. So sometimes For you to do this, you have to calculate the percentage of body bent separate, or they will give you percentage of body bent, but because they want you to still do something or figure something out, they will just put the weight in pounds, or they will put the 4 ml of lactated ringers, which is the best solution to replace. In 24 hours, they will just put the fluid. They can give it to you in ounces, and they want you to convert it to cc. This brings us back to our calculation, remember. So how much of fluid do you give in the first 8 hours if a patient is bent? You give half of the total volume. So the first 8 hours, patient is supposed to get half of the total fluid volume. After you have calculated the amount the patient is going to get for 24 hours based on the body surface that is bent, then the patient is supposed to get half of the total volume. Now, how much you give in the second 8 hours, making it 6 hours, you give 1/4, 1/4 of the total volume. So the first 8 hours, you give half of that 24-hour solution to it. So if the patient is going to get, let's say, 6 liters, so the first 8 hours, I will give 3 liters. And now the next 8 hours, the patient gets 1/4, 1/4 of the other 3 that was left. Now the next 8 hours, we know 8, 8, 8 makes it 24. So the first 8 hours is half of the fluid. This is 1/4 of the fluid, and then another 1/4 of the fluid, making it half. Combine it to the first half, 24 hours. So that's how you administer the fluid. So the first 8 hours, you need to go faster. Should you, so if the patient has a blister, the patient got burnt and they have a blister, should you burst it? No, you don't burst blisters on patients with burns. When they get burned, you don't burst it. You don't even use your hand. I remember I had a question on that. You don't use anything that will cause the blisters to burst. You can use like a soft gel or like a spatula to put an applicator, to put things, to put the lotion or whatever cream you have to put on it, the silver sulfidizing or anything you're going to put on. You don't put in on a hard surface to burst the blisters. You don't burst them. So the best route for pain medication for a burn patient is through IV. The best route for you to give a patient pain medication if they have burns is through the IV, not oral. Okay? So the diet for a client who has burns is high calorie, high protein diet. If you get burnt, high calorie, high protein burn. Protein will help you with the healing as well. So the common electrolyte problem that patients with burn face is hypokalemia, low calcium, and no, hypokalemia or hyperkalemia is 2 ways. You can either suffer hyper or low potassium, high potassium or low potassium, and both can be seen in clients with burns. So it's not only one of them. So if they're giving you a burnt client and they're giving you hypokalemia, you have to understand that it's possible. If they're giving you another one and they have hyperkalemia, understand that it's also possible. Now let's talk about Kerlin ulcers. Kerlin ulcers. So this one is due to the prolonged stress. So the client are at risk for Kerlin ulcers. You also want to give them pain medication before you discharge them. So patients who has burns, they have pain, so you have to give them pain medication. Remember, pain treatment is very necessary. What time is it? 23. So I'm going to stop at 8:30. But before I stop at 8:30, let's talk about cataract. Cataract. I'm going to talk about cataract. Cataract, you know, cataract, like the eye problem, eye cataract. So the signs of cataract are milky white lens, painless, blurred vision. You have blurred vision, but it's painless. You will not have pain, but you have blurred vision, painless, milky white lens. When you look at the patient's eye lens, it will look milky white. So basically there's no treatment for cataract until vision is impaired. So if there's no vision impairment, there's usually no treatment for that. But when you have vision impairment, then you now need cataract surgery. So patients that tell you, oh, I have cataract surgery, they've had it for a while, but they just didn't have vision problems. Now they start having vision problems, they will need cataract extraction and a new lens implanted. I don't know who has seen an eye surgery before, but this one surgery I saw that I always feel like I couldn't have been an eye nurse, ophthalmological nurse or ophthalmology nurse. So they cut the eye, they scoop the eye out, and then they cut it and push the lens in. They pull the old lens, the small lens out, and they push in a new lens inside your eye, and they push it back into the eye socket. So they remove it.
Like that?
You say?
Do they use it to see like that?
Are they able to see like that?
After the surgery, yeah. Do they use that one to see?
Yeah.
Maybe.
It's a lens they are putting, even though it's an artificial lens. But remember, those people that donate eyes too, they can take somebody's eye and they put it, but they are able to see after that. Yes. That's why they do the replacement. They take the lens out and they put it for you to be able to see. So it's just a small thing. They just pull it out, then they use something and push it back in. It looks weird to me. So if only a new lens is replaced, the patient's vision will be restored. Okay, the patient's vision will be restored. So after surgery, the main concern is hemorrhage of the eye. The eye can bleed after the procedure. So you want to place the patient in semi-Fowler's position. Semi-Fowler's position. So what do you tell a client about the cataract surgery? Your advice would be that you have to teach them to avoid like coughing, sneezing, bending over, like scooping over, stooping over at their waist. They need to stop bending and stooping over. Then straining and rubbing their eyes or crying are not allowed. Lifting greater things that are heavier than 5 pounds, you put stress. So you want to teach the patient. Coughing, sneezing, it can all cause the eyes to pop up. So bleeding is a problem. So post-operatively, they need to sleep on the unaffected eye. So if I had a surgery on this eye, I need to sleep on the other side, like this. So you have to sleep on the opposite side. Don't sleep on that same side of the surgery. Or if the surgery was on both eyes, the patient has to sleep on the back. If they did the cataract on both eyes, sleep on the back. So you also tell them to use eye shield at night when they go to bed. So you see a patient walking with the eye shield. They do that for, I think they usually instruct them to use that for at least 6 weeks, and then they are fine. So on that note, I'm going to talk about celiac disease, and that will be our last for the night. Celiac disease. So celiac disease, we all know, is an abdominal problem. Foods that contain gluten, they are the people who cannot eat it. They cannot eat gluten-containing foods. Patients with celiac disease cannot eat foods that contain gluten. And they have a problem with fat absorption. They have fat absorption problems. So they cannot eat foods that contain gluten. Now let's talk about foods that contain gluten. I have the brow, B-R-O-W, B-R-O-W. So if you have ever heard that acronym before, B-R-O-W, when they give you that client, or when the Nclex present to you a patient who tell you, I'm eating this brow diet, you should know what they are eating that for. They are eating that because they are patients with celiac disease. They have fat absorption problem, fat malabsorption problem. So because of that, brow food does not contain gluten. Brow has to do with barley, rye, oats, and wheat. Barley, rice, oatmeal, and wheat. These are food that do not contain gluten. So the patient with that problem is good to eat that kind of food stuff. So it's okay to let them eat the brown food. So the client abdomen is usually distended. So if the patient has the celiac disease, you see that they have distended abdomen, and their stool look like it's pale. They have a pale color stool, and it's smelly. They have a bulky stool, and you also expect a lot of gas and diarrhea. They sometimes have diarrhea as well. The best food substitute for this bowel thing is corn and rice. Corn and rice. These are foods that also contain less of gluten. So corn and rice is the best food supplement or best food to replace the brow. If the patient cannot be eating barley, rye, oatmeal, and wheat, the other thing they can eat is corn and rice stuff. So a client with gluten-free diet, I'm trying to talk about cookies. So if somebody has celiac disease, they have to eat gluten-free diet. And gluten-free diet can be cookies, spaghetti, or waffles. So know that all these products have grains in them. So the patient can have them. The patient can have cookies, they can have spaghetti, and they can have waffles. Remember that all these things are grain. Mostly this all-purpose flour, you check and it is wheat flour, but they have a product of grain in it. It's a grain product that they use to make all the flour. So the patient can have that. And the other name for celiac disease is celiac sprue. Celiac sprue. Celiac sprue. So just remember that patients with celiac disease, they are supposed to eat the brown food or the brown diet. When you are advising a client on discharge who is going home, you explain the condition to them that their problem is that their body is not able to absorb fat. And this fat is called the gluten type. So for food that contain gluten, they shouldn't eat it. But these are the food that are usually prescribed for you. And this food is what you need to stick on so that you don't have a flare of it and you keep coming back to the hospital. So you will take the brown diet, and the brown is barley, rye, oatmeal, and wheat. That's the brown diet. And if you cannot take that one, try to eat more of rice and corn. But cookies, spaghetti, and waffles are good for you too because they are all made up of grains. So things that are made up of grains, but don't go and eat a cheesecake, cheeseburger. Those things are fatty and they have gluten in them. So diet too is another component of the Nclex you need to know. You need to know what food is in this particular diet. Okay, so on this note, can we end our class for tonight?